So again, welcome everyone. Thank you for joining us for this session of Questions and Experts hosted by the Canadian Breast Cancer Network. Today, we will be speaking with medical oncologist Dr. David Cescon and taking your questions about triple-negative breast cancer. I'm Jen Gordon, the Director of Operations with the Canadian Breast Cancer Network, and I'm pleased to welcome you today. We've now hosted several questions and experts sessions that were previously recorded and are available on our website. So I'll pop that link into the chat for those of you who may have missed them and may be interested in some of the other sessions that have been recorded. I'll also post a link to CBCN's newsletter so that you're able to be notified of other sessions that we have scheduled. This is the last one for 2021, but we will continue this series in 2022. So I'll make sure that's in the chat as well shortly. I would like to extend our sincere appreciation to the sponsors for this session today who have made this programming possible. So our gold level sponsor, Beatrice, our silver level sponsors, Novartis Oncology and Roche, and then our bronze level sponsors, AstraZeneca, Knight Therapeutics, the Ontario Trillium Foundation, and Pfizer. We will be taking questions throughout the session today, and we encourage participants to submit these questions using the Q&A icon that you should probably be able to find at the bottom or the side of your screen. If you can't find that, please feel free to submit them through the chat as well, if that's the only button that seems to appear on your screen. We have some questions submitted in advance, so we'll start with those and then flip between the live questions and the ones that were submitted in advance of the call. So I'd now like to welcome our host for today's session, Kathy Amanda Lea, who is the chair of the board of the Canadian Breast Cancer Network. And Kathy has personally experienced a breast cancer diagnosis and really understands firsthand how important it is for patients to have the opportunity to ask their questions and have them answered. So Kathy, over to you.
Thank you, Jen. Hello, everyone, and welcome back. If it's your first time joining us, welcome. I'm pleased to introduce our expert for today, Dr. Cescon. Dr. Cescon is medical oncologist and clinical scientist at the Princess Margaret Cancer Centre in Toronto. He is a member of the International Breast Cancer Clinical Trials Working Group, including the National Cancer Institute and Breast International Group, as well as being in a leadership role with the Canadian Cancer Trials Group. He is also the principal investigator in the Terry Fox New Frontiers program in triple-negative breast cancer. Welcome. It's great to see you again, and thank you for joining us.
Thanks, Kathy. Thanks, Jen. Pleased to be here, and welcome to all of our participants today. Look forward to the discussion.
Okay, so as Jen mentioned, we'll begin with some of the questions that were submitted in advance and then move on with some live questions. So let's get started. We have a question. Since this session is focused on triple-negative breast cancer, perhaps you could first provide us a high-level overview of what that means.
Sure, great question. I think good opportunity to set the stage for the rest of our discussion. So, without assuming any given particular level of knowledge that people are attending with today, I'll start by perhaps highlighting that the way that we clinically diagnose and treat breast cancer is really based upon the tumor features or markers for hormone receptors. That's ER, estrogen receptor, PR, progesterone receptor, so the female hormones, and HER2, which is another receptor which is involved in the growth of certain subsets of breast cancer cells. So with those three markers, ER, PR, and HER2, we can define the three main classes of breast cancer. Hormone-related breast cancers or hormone-sensitive breast cancers that are ER and or PR positive. HER2-positive breast cancers, which are those that have overexpression of this marker HER2, or triple-negative breast cancers. And triple-negative breast cancers is that subset that do not express the female hormone receptors, ER or PR, and do not have overexpression of this HER2 marker. So triple-negative breast cancer there is really a diagnosis of exclusion of those other markers. The definition of triple-negative breast cancer really came when HER2 was discovered as an important marker for breast cancer nearly 20 years ago. And when we think about the proportion of breast cancers that each of these groups represent, triple negative breast cancer probably comprises around 15% of breast cancers that are diagnosed. HER2 positive, about another 15%. And then the majority of breast cancer are those that are hormone receptor positive.
Great. That's a very good overview. So given that triple negative breast cancer is essentially an absence of a target, would it be helpful for patients with triple negative breast cancer to receive genomic testing or some type of additional testing to see if they have a marker that may help provide information about their cancer?
So great question. And here, here we're really jumping, I think, right into the meat of it. If we, again, take a step back and think about how those receptors, right, the 3 receptors where we're diagnosing triple negative on the basis of the absence of, those markers are important for some of the standard treatments that we think about for breast cancer. So the hormone receptors are important determinants of who may benefit from hormone-based treatment when we think of drugs like tamoxifen or aromatase inhibitors. HER2 positive breast cancers have a specific sensitivity or vulnerability to drugs that target HER2. And there's a whole variety of drugs now that have very effectively been used to target HER2 positive breast cancers, reduce the risk of recurrence in those diseases, and markedly improve survival for patients with metastatic HER2 positive breast cancer. So for triple negative breast cancer, we don't have those tools available to us. Hormone-based treatments are not useful. HER2 targeted treatments, at least historically, have not been useful. And the mainstay of treatment has really been chemotherapy. And when I'm talking about the mainstay of treatment, I'm talking obviously about drug-based treatment as a medical oncologist, right? Surgery, radiation have a role in all subtypes of breast cancer for the treatment of local disease. But for drug-based or systemic therapy for triple negative breast cancer, historically we've had chemotherapy. And that chemotherapy has not been, again, historically used or delivered on the basis of other markers of the tumor cells themselves. We use other information about the tumor, right? How large is it? Are the lymph nodes involved? How high risk is this cancer? What's the other characteristics of the patient, the situation that they're in, to help decide whether or not to use chemotherapy or perhaps what chemotherapy to use. But there hasn't been a specific tumor marker that we've used. Over the last few years, we have seen some emergence of some new treatments or new treatment options that are relevant to triple negative breast cancer. I imagine we'll get into some of those specifics later. But with the advent of those new treatments, there are some emerging markers for triple negative breast cancer, which might play a role for drug-based treatment. And that role may be relevant to the treatment of early breast cancer, or it may be relevant to the treatment of advanced or metastatic breast cancer, again, depending on the scenario. So the one marker which has been a well-established marker for helping to guide treatment for triple negative breast cancer is not a tumor marker, but is a germline marker or a blood-based marker, BRCA. So people are probably familiar with BRCA1, BRCA2, which is an inherited predisposition to breast cancer. And BRCA1 mutations in particular dramatically increase the risk of triple negative breast cancer. So again, that's relevant to the risk. BRCA1 and 2 are relevant to the local treatment of breast cancer. I'm sure this was addressed in some of the other Q&As. But BRCA is also useful to guide drug-based treatment because certain types of chemotherapy may be more effective in people who have a BRCA1 mutation. And there we think about, particularly for advanced disease, it's been shown that platinum-based chemotherapy has a more important role for BRCA1 mutation or BRCA mutation carriers, both BRCA1 and 2. And PARP inhibitors have been approved specifically for BRCA-related breast cancers for metastatic disease. And so there again, this is not tumor-based profiling, but is genetic information, which does guide our use of treatments for advanced breast cancer. There are some emerging markers which may be relevant to the treatment of advanced breast cancer. So that includes, again, not a genomic marker, but a different protein marker, PD-L1, which is useful to identify patients who might benefit from immune-based treatments for metastatic triple negative breast cancer. And in early breast cancer, we've had some recent data which suggests the utility, again, of that BRCA1 marker for helping to guide adjuvant treatments or treatments for early breast cancer. If we think about tumor-based genomic information, so again, I'm not sure how familiar people are with tumor-based genomic profiling. It's something we could talk about later too, or if other questions come up. This is where we think about looking for specific mutations in the tumor which might help to guide a given therapy. And while triple-negative breast cancer is characterized by having a large number of mutations within the cancer relative to other subtypes of breast cancer, right, in that it tends to be a type of cancer where many mutations accumulate, those mutations don't currently have a major role in how we treat triple-negative breast cancer. So unlike ER-positive breast cancer, for example, where there are some mutations that are prevalent in a significant proportion of patients and we have drugs that are matched to those mutations, that's not currently the case for standard treatment of triple-negative breast cancer. This remains an area of active investigation, trying to use that tumor genomics to inform the use of either existing or emerging therapies. So to encapsulate, tumor-based genomic testing, it doesn't have a critical role in treatments today. Germline testing, so testing for the inherited BRCA1 and BRCA2 genes, does have a role, and tumor-based testing for other protein markers, PD-L1, has a role in metastatic triple-negative breast cancer today.
So then just a quick follow-up question to that. In terms of the standard of care then, should triple-negative breast cancer patients all be receiving that germline testing to see if they have that BRCA1 or 2 mutation to then inform their treatments? Is that a standard of care? Is that happening across Canada, or is that still depending on the center that you're in or maybe the province that you're in?
Sure, that's a great question. And, like other things in terms of funding for certain tests or treatments, there will be provincial variability. Historically, the testing for BRCA1 and 2 has really been driven by identifying people's risk for developing breast cancer so that preventative strategies can be employed for family members or for future prevention for that individual that's related to breast or ovarian cancer. And because because triple-negative breast cancer is the subtype of breast cancer where these are most common, and where there also tends to be a younger age of onset, which is associated with the presence of these germline alterations. Testing for germline testing in triple-negative breast cancer has been probably more widespread than in other subtypes of breast cancer for the last few years, and appropriately so. Again, that was not mostly driven by systemic treatment decision-making, but was rather driven towards local treatment decision-making and familial counseling. We have definitely seen that over the past several years, the utilization of germline testing for breast cancer has increased. Again, I can't quote you specific numbers on this, but certainly it's increased. The accessibility of these tests have improved, in that the cost of getting this type of testing has fallen, more places to get it. In fact, there are direct-to-consumer type ways to get this testing done now. So it makes it much more accessible. And, I would say that in my practice, where this information for patients with advanced metastatic breast cancer is relevant to treatment decisions for either what chemotherapy they would get or whether they may be eligible for a PARP inhibitor, that this would be a standard of care type of test. And for early breast cancer, again, much of the decision-making and much of the importance of BRCA1 testing for early breast cancer is focused on surgical decision-making. That with the advent of PARP inhibitors as a potential tool as adjuvant therapy for early breast cancer, that we will see an increase in germline testing for early breast cancer. I think it's important to note that PARP inhibitors are not currently approved in this indication in Canada. They are in other jurisdictions, but not yet in Canada. And funding access to those treatments, because it's not approved, is generally not available in Canada. and that not every person with triple negative breast cancer would be a candidate for a PARP inhibitor, even if they had a germline BRCA mutation. The studies that tested those drugs were in people who had higher risk disease, and therefore the importance of the testing to guide the use of those therapies needs to be aligned with in whom would those treatments be potentially used. So it doesn't necessarily mean universal testing of everyone, although I think many of the perceived downsides of germline testing historically, right, high cost, difficult accessibility, hard to understand or interpret the results, lack of patient information, and concerns around insurability, et cetera, are certainly seem to be less apparent now than they did 5 years ago.
Great, thank you. I have a quick question. If a patient is diagnosed with triple negative breast cancer and it does not have the BRCA gene, either one or two, does that automatically make a family member at high risk, like it would if you've discovered that the patient has the BRCA gene? Is it in that same?
No, so that's a great question. So triple negative breast cancer, like other breast cancers, can be familial. They can be familial related to a specific alteration, or they can be what we call sporadic. Breast cancer is a common cancer. It's a common disease. As you know, more than 10% of women in Canada will develop breast cancer in their lifetimes. And most of that is not driven by a specific, identifiable genetic risk like BRCA1 or BRCA2 or, a number of other less common specific germline alterations where risk is extreme, is very high and can be easily identified. There are people who have familial breast cancer, so where there may be multiple family members who are affected, but do not have BRCA1 or 2 or these other genes. And part of this reflects the fact that risk is complex and may be multifactorial in that there could be many small things that those people have inherited that increases the risk of breast cancer that we don't really currently understand or have the ability to measure, right? So that would be familial breast cancer, but lacking one of the identifiable risk genes. Or the sporadic breast cancer. So just because a person has triple negative breast cancer doesn't mean that their family member is at particularly increased risk of having breast cancer. Having a family member with breast cancer is a risk factor for breast cancer in general, right? Because of the multifactorial component that goes into breast cancer risk. But the high risk is really limited to those either who have a strong family history, right? Multiple affected family members, or those who have a demonstrable risk gene like the BRCA1 or 2 that we talked about.
Thank you. Do you see more patients with triple negative breast cancer who are metastatic at their first diagnosis when they come in with, and you're diagnosing them for the first time compared to with the HR positive or HER2 positive patients?
Yeah, so that's also a great question. So, often triple negative breast cancer is thought of as an aggressive subtype, which has a higher risk for metastatic spread or recurrence. What you've described, the phenomenon of having metastatic breast cancer, stage 4 breast cancer, at the time of initial presentation, right? So this is someone who didn't have a history of an early breast cancer that was treated. This is metastatic disease at the time of the initial presentation, where we call de novo metastatic is kind of the medical terminology. The risk with triple negative breast cancer is a bit higher than it is with, for example, ER positive breast cancer. But the vast majority of people with triple negative breast cancer and the majority of people who ultimately develop metastatic triple negative breast cancer are originally diagnosed with non-metastatic breast cancer. Okay. And for triple negative breast cancer, again, the likelihood that there is metastatic disease at diagnosis is a bit higher than ER positive disease, for example. Part of that is related to the fact that many breast cancers, particularly ER positive breast cancers, are diagnosed by mammographic screening, right? And triple negative breast cancers, because they tend to be more rapidly growing, are more likely to present between scheduled mammographic screenings. And triple-negative breast cancers occur with a greater frequency in younger women, where mammographic screening may either not be standardly used, or where mammographic screening might be less effective because of breast density and other factors. So there would be an increased proportion of triple-negative breast cancers that are not screen detected as compared to other cancers. And when you're detecting people with screening with very small ER-positive breast cancers, for example, the likelihood that those are metastatic at the time of diagnosis is extremely small. So it shifts that balance of between the subtypes of the likelihood of having metastatic disease. But again, the key points here is the vast majority of triple-negative breast cancer is not metastatic at the time of diagnosis. And the majority of patients with metastatic triple-negative breast cancer, people with metastatic triple-negative breast cancer, had a previous diagnosis of early breast cancer.
Okay, that's very helpful. Thank you. Jen, would you like to go to live questions now?
Yeah, and actually, since we're on the topic of mammography and dense breasts and whatnot, we have a question here around 3D mammograms. So would a 3D mammogram be more effective than a regular mammogram for dense breasts and after a lumpectomy and reconstructive fat grafting? And then also a question that ties in with that around, are there other scans that should be used to help detect recurrence?
So great question. With respect to the breast screening or the mammographic screening, this is really principally the purview of the surgeon or radiation oncologist. So as a medical oncologist, at least in our center, we defer that ongoing mammographic screening or ongoing breast surveillance to our team members who are principally focused on what's called local regional disease, right? The disease in the local area. So there's a variety of different imaging, techniques that are used either for breast screening or surveillance, including standard mammograms, tomosynthesis, MRIs, ultrasounds that are used to follow up abnormalities on mammograms, for example. And so each of those have a defined role. But for the vast majority of people, mammograms remain the standard approach for surveillance. I think there was you noted in the question something about someone who's had reconstruction. With someone who's had bilateral mastectomies, for example, screening would not be part of the ongoing surveillance there if there's no breast tissue that remains. Someone who had a mastectomy, if they're having clinical follow-up for signs of a local recurrence, right, which could happen despite there being no breast tissue, because the local recurrence can happen in the skin or in the subcutaneous tissues. That's done by clinical evaluation, not by imaging. The question you asked about other imaging tests or other surveillance that could be considered after definitive curative intent treatment for an early breast cancer is one that often comes up. And I think people are often surprised by the answer, is that there is no routine imaging surveillance or really any type of diagnostic surveillance for people once they have completed the standard curative intent treatment for their breast cancer. So apart from breast screening, as is relevant and depending on the specific situation, we don't do CT scans at any interval. We don't do routine blood work at any interval as part of the routine standard of care. The only tests that are done routinely as part of standard of care currently would be tests that are prompted by some symptom or other concern, right? If someone has some symptom which is concerning for a clinical recurrence, then appropriate diagnostic tests would be ordered to investigate that. That's not surveillance, those are diagnostic tests that are done to work up a clinical concern. So at present, no surveillance apart from standard clinical follow-up, history, physical, with use of diagnostic testing where appropriate. This is a major area of ongoing interest and research, recognizing that there are both new diagnostic tools that have been developed and are being developed, as well as new therapies which might be useful for early intervention if these recurrences could somehow be picked up early. The reason why we don't use imaging surveillance, or why imaging surveillance has not been historically seen to be useful, is that finding asymptomatic but radiographically detectable, meaning something you can see on a CT scan, right? A metastatic recurrence that you can see on a CT scan in the lung or the liver or the bone. That disease is incurable or stage 4 disease based on our currently available treatment. So surveillance to detect that type of disease has not been shown to improve long-term outcomes or survival for people with breast cancer. So there's a real effort to try and move that dial back, right? Are there ways to detect the disease more precisely before it becomes radiographically detectable, right? Like there must be some cells around to detect, but if they haven't formed a tumor that you can see, perhaps the level of disease that's there is at a threshold or below a threshold where we can still eliminate all those cells and achieve cure. And so this is not standard of care. This is investigational approaches, but we do have clinical trials in certain settings, including triple negative breast cancer, that are evaluating strategies like that. So using tests to identify people who have subclinical evidence of residual disease, it's called minimal residual disease or molecular residual disease, for which some intervention, right, if the intervention was useful, might be able to eliminate it, achieve cure, or delay or prevent recurrence.
So you've described a whole battery of imaging like CT, et cetera. What about chest X-ray? And chest X-ray, you can, I would imagine, detect something in the lungs, for instance. Would that be beneficial?
Yeah, so I kind of spoke to CTs as standard screening tool, but this extends to chest X-rays or liver ultrasounds, those things. So again, yes, a chest X-ray could detect a tumor in the lung. If we think about the resolution of a chest X-ray can generally, reliably identify a tumor or a lesion that's, say, a centimeter in size, depending on where it is. It's hidden behind a rib or something, but let's say a centimeter in size. So disease that's visible on a chest X-ray, like disease that's visible on a CT scan, right? Metastatic disease is visible whether it's CT or chest X-ray or liver ultrasound. That's metastatic disease, which is not curable, based on our current breast cancer treatment paradigms. And this is where studies that were done historically, looking at surveillance with things like chest X-rays, liver ultrasounds, more frequent blood work, did not show that patients who had that type of surveillance live longer than those who did not have that type of surveillance.
Thank you. Thank you. So we have a couple of questions that have been submitted around the recurrence. Perhaps you could speak to what factors increase or decrease a risk of recurrence, and then we can discuss a couple of scenarios.
Sure. So, like other types of breast cancer, the main factors that we consider in trying to assess an individual's risk of recurrence are, what is the biological nature of the disease, what does it look like under the microscope, and how much disease, what's the stage of the breast cancer at the time that it's diagnosed, right? If we're talking about local regional disease here. So as we started off with, triple negative breast cancer tends to be the subtype of breast cancer where the risk of, it's a biologically more aggressive subtype. So when the pathologist looks under the microscope, right, triple negative breast cancer defined by the absence of those receptors that we talked about, as well as other features that the pathologist can determine the grade of the cancer, how fast the cells appear to have been proliferating before the tumor was removed. Those things are associated with an increased biological risk, which is inherent to the subtype. By and large, there are some rare subtypes of triple negative breast cancer which are less aggressive. Those comprise very small minority of the overall disease and really require careful pathologic diagnosis. But for most triple negative breast cancer, we can consider this as a high biological risk, right? And so then the other piece of the risk, the anatomical risk. So how big is the tumor at the time that it was identified and removed, and were the lymph nodes involved or not, and if they were involved, to what extent. So those factors allow us to estimate what the tumor-based risk of recurrence is. Obviously, larger cancers, more lymph nodes involved have a greater risk of recurrence, smaller have a lower risk of recurrence. That risk needs to be interpreted in the context of the individual who developed that cancer, right? So someone who's young, healthy, has no other medical problems, and whose life expectancy would otherwise be, another 50 or 60 years, which is not uncommon if you have a healthy 30-year-old who's diagnosed with breast cancer. They have no other competing risks to their health, at least in the short term. That's different than someone who might be much older and have many other medical problems where their life expectancy is different as a consequence of their general health, right? So we take both of those things into consideration. What's the risk of the cancer? How does that risk of the cancer compare to the other risks that an individual faces in the relevant time frame? We'll talk about what the relevant time frame is, but the relevant time frame for triple-negative breast cancer, to be able to assess, ascertain the risk, and then discuss the types of treatments that would be warranted to reduce that risk. And here again, the types of treatments are largely chemotherapy, as well as some of these newer treatments that are emerging as adjuvant therapy.
So still in keeping with the recurrence discussion, when someone recurs, say 5 years later or a little longer, how often do they recur and have a different biology of their tumor where something else will appear, like HER2 or HR?
Yeah, good question. Yeah, so a couple of things. So, your question there around a timing of recurrence of, say, at 5 years. So one important or useful thing to think about with triple-negative breast cancer is that the temporal risk, or the time of risk for a recurrence of triple-negative breast cancer, tends to be front-end loaded versus ER-positive breast cancer, in that recurrences of triple-negative breast cancer tend to occur in the first, within the first 3, 4, 5 years. And recurrences can happen thereafter, but the risk of recurrence drops off significantly as you get out into that time frame. Whereas with ER-positive breast cancers, that risk of recurrence can continue into a longer time. So, you said a risk, certainly triple-negative breast cancer can recur at 5 years, as you described, but most triple-negative breast cancers, if they're going to recur, tend to recur at an earlier time point, 1, 2, 3 years after the original diagnosis and treatment. So the recurrences that we're talking about, again, are principally metastatic recurrences, right? Recurrences that happen outside of the breast or the lymph nodes. People who have had a diagnosis of triple-negative breast cancer can obviously develop a new breast cancer, right? Same breast or the other breast. That new breast cancer might have different features. You're positive, be HER2 positive. So that's a new breast cancer, right? That's different than a recurrence of the triple-negative breast cancer. Triple-negative breast, so if we think about the receptors and changes in receptors that can happen with metastatic recurrences, it's a well-recognized phenomenon. Generally, however, triple-negative breast cancers don't tend to change their phenotype or their expression profile with recurrences. They tend to be, if you have a triple-negative breast cancer at the original diagnosis, it tends to be the same. In fact, all breast cancers tend to be the same, but especially with triple-negative breast cancer, it's very highly likely to be the same. For other types of breast cancer, we do see some rates of change. The rate of change, switching in the receptors that influence treatment in a meaningful way probably happens around 1 in 7, 1 in 8 cases. The most common effects that we see probably is loss of the ER expression in people where the ER expression was not high to begin with. And this may be influenced obviously by the treatments that have been given in the intervening, so that the cells that survive whatever treatment were given have been selected in that fashion. But triple-negative breast cancer, again, a recurrence tends to be the same as the original diagnosis. We do, because there is some possibility of a change, or because there's a possibility that someone might develop a new, different type of cancer, we still do favor rebiopsying metastatic disease at the time of a recurrence. In many cases, and there are situations where clinically it's very, very apparent, or there's no clear need for a biopsy, or a biopsy is difficult to do because of location of the tumor, or because there's some urgent need to initiate treatment, and so biopsy is not done. But generally, we do like to rebiopsy metastatic disease for the reasons you said. Confirm this is a recurrence of the original cancer. Confirm that this has the same appearance as the first cancer. Because if there was a change in the receptors, it could influence treatments that
the
are
treatment
delivered.
plan. Yeah, right. Thank you. So a question here. So for someone who is 5 years post-treatment with no recurrence, where do they sit in terms of, no, sorry, we covered that one. What about someone who had triple negative breast cancer 15 years ago and then recurred 2 years ago with cells in their lymph nodes? Does that place them at a higher risk of recurrence?
So this is an interesting question, and I think, again, reflects what we just talked about, right? So a true recurrence of triple negative breast cancer after 15 years is a pretty uncommon occurrence, right? Most of those triple negative recurrences happen relatively early on. A recurrence out to 15 years with triple negative breast cancer is pretty unlikely. And so this is a situation where if someone had a recurrence or an apparent recurrence of breast cancer after 15 years, if the original diagnosis was triple negative breast cancer, we would certainly want to very carefully evaluate this new cancer, because I think there would be a high likelihood that this is actually a new cancer, or is different in some way, or at least that their original triple negative breast cancer was unusual in some way because it's now recurred in a way which is not typical for triple negative disease. So, are they at a higher risk or not? This is obviously a situation where the risk needs to be assessed on an individual basis. What was the original cancer? What treatment was delivered? What is the actual extent of the recurrence? Is there a new tumor in the breast, or is it just in the lymph nodes? What are the features of this current cancer? And all those factors needs to be taken into consideration to determine what that person's risk is and what the appropriate management would be. 15 years would put us back to the mid 2000s, where HER2 testing was becoming standard of care, or had become standard of care, but sort of just. And so, someone might not have had HER2 testing done on their original cancer in the early 2000s. Some of the processes for staining, other things have changed. So careful reappraisal of the original pathology and of the pathology of the recurrent disease would certainly be warranted in this kind of situation.
Thank you. So another question is, what are some things that patients can do to reduce their risk of recurrence? For example, does alcohol increase the risk of recurrence? And what other modifiable risk factors? I guess alcohol can apply to any breast cancer.
Yeah, sure. So I think really many of the things for the non-pharmacologic or non-medical kind of approaches for reducing risk of recurrence are not specific for triple negative breast cancer. Many of these things are, the extent that these things may be beneficial are not well characterized for, again, different breast cancer subtypes. And we probably understand less about the impact of these kind of things to prevent recurrence than we do for modifiable risk factors for breast cancer in general, where obviously there's many more people where that can be studied. I think in general, I would say, so number one, alcohol moderation is important both for breast cancer risk and probably for recurrence risk. It's probably I would consider that across the spectrum of breast cancer. Other factors that are useful and modifiable include things like body mass. So trying to achieve and maintain a healthy body weight is probably useful for reducing risk of breast cancer recurrence. It's good for other health outcomes as well. And certainly we know that people who have been treated for breast cancer, who have other drugs that might have cardiovascular risk in the long term, et cetera, achieving and maintaining a healthy body weight has many benefits for that survivorship piece. Exercise is another thing. Again, exercise may be beneficial independently of diet and weight, by stimulating the immune system or in other ways that we don't truly understand in great detail, that could be useful both for the purposes of trying to modify risk factors for breast cancer recurrence and for the healthy living that goes along with breast cancer survivorship.
If someone has applied all this to their lifestyle before a diagnosis, not drinking, good exercise, good quality of life, doing all what you described, how do you change that or modify that after you've been diagnosed?
Yeah, so this is, you know, great question. And when we think about modifiable breast cancer risk factors, right, the one thing that people, you know, often think of, commonly ask, is it because I did this that I got this breast cancer in the first place? And the answer to that is, you know, universally no, right? There's nothing that someone did or didn't do that caused them to get the breast cancer that they were diagnosed with. And I see, you know, unfortunately, far too many people who, like you described, were doing the quote right things, right? There was no obvious thing that they might have changed to reduce the risk of developing breast cancer in the first place. And so, you know, maintaining those habits in the best way that they can. And it doesn't mean that, you know, having a unhealthily low body weight is going to reduce, right? If you have a healthy body weight to start with, doesn't mean you try and achieve an unhealthily, you know, low body weight. It means try and maintain those, the healthy lifestyle that you had to begin with. And again, that can be challenging after a breast cancer diagnosis, where we know that, you know, weight gain and other things commonly occur related to the diagnosis and treatment that happens for that initial breast cancer. So trying to maintain that healthy lifestyle that you described would be definitely what I would encourage.
Thank you. Jen, are you going to ask us live questions now?
We do. We actually have a couple that would fit in well right now. So one around, what are some of the signs and symptoms that patients can look out for in regards to possible recurrence that they maybe could be noticing or more mindful of?
Yeah, so this is you know, a tough thing for you know, anyone who's had a diagnosis of breast cancer to manage, right? It's managing the anxiety around symptoms, but at the same time, not ignoring things that could be important, that could lead to a delayed diagnosis and recurrence. So, you know, we can think of the common places that breast cancer tends to recur, right? Obviously, you know, recurrence in the breast or lymph nodes is possible. And so thinking about, you know, a new lump or skin changes, triple negative breast cancer can recur in the skin. So, you know, a new rash or something in the breast, this is something which needs to be, you know, carefully assessed. Other common sites of metastatic disease for triple negative breast cancer specifically include in the liver, in the lung. Bone is a common place for recurrence of any breast cancer subtype. It can happen with triple negative breast cancer. Brain is another site where triple negative breast cancer has a greater propensity for spread than other subtypes. So what does that mean? You know, what specific symptoms do you look for? I think there's not specific symptoms that you look for. I think being mindful that, you know, every headache that you have or every pain in the back that you have is not likely to be your breast cancer, right, is important, but that something that is out of the ordinary, persistent, progressive, is certainly something that should not be ignored and should, you know, probably initially prompt, you know, discussion with someone's family physician who, you know, plus or minus referral to their oncologist for further assessment as warranted. A recurrent cancer, metastatic cancer, unfortunately, is a progressive disease, and therefore the symptoms of metastatic cancer tend not to be, you know, intermittent or fluctuating in nature. It's not something that comes and goes, you know, once a month. They tend to be persistent and progressive, and certainly those things should not be ignored.
Okay, thank you. And then a question around chemo. So what is the risk? Does chemo increase your risk of other diseases? And could you speak to that a little bit as well?
Yeah, great question. So there's different types of chemotherapy, and you know, some of the different chemotherapy drugs that we use have different toxicities, either short-term or long-term. You know, we commonly think of you know, one of the classes of drugs that's used for breast cancer, anthracyclines, as having a risk of cardiac dysfunction. Other drugs, the taxane drugs, which are commonly used, have a risk of neuropathy, right, numbness and tingling in the fingers and toes, for which some people can experience long-term. The important thing to understand is that, you know, chemotherapy has recognized toxicities and recognized risks of toxicities. It's used in a way, the whole point of that risk assessment that we talked about, right? What is the risk of developing incurable or lethal metastatic disease, is used to help balance the risks and benefits of that treatment. So, you know, the goal is only to recommend and use chemotherapy where someone's long-term survival is likely to be improved by that. Again, recognizing that unfortunately, some people will experience side effects which may have persistent symptoms, affect their quality of life, or contribute to other health-related issues, but at a much smaller risk than the survival benefit that is achieved by the use of that treatment. So, on average, each person who gets that treatment will be much better off having received it. Recognizing that, again, we don't know upfront who specifically is going to be cured by that treatment, who specifically is going to develop the toxicities, but a careful assessment of the risk, both of toxicities, right? So what factors might predispose someone to toxicity from a given chemotherapy is important, and what factors or how high is the risk of a recurrence is important, so that we can best personalize the chemotherapy decision for each individual.
I just have a quick follow-up. In terms of receiving chemotherapy, years later after having chemotherapy, could patients still have symptoms or develop symptoms years later, even if they've not experienced any in between? Like, could you develop?
Yeah, so late toxicities of chemotherapy can occur. And cardiac dysfunction is one of those risks historically. I think we know better. We know much more about these drugs now, their long-term risks, how to identify patients who are predisposed to those things. So there are potential risks that can develop, or toxicities that can develop later, but by and large, these are very infrequent type of complications of chemotherapy.
Jen, do you have any more live questions, or can I go to the submitted questions?
We do. I think we can hop back to the submitted questions, and then we'll do a few more of the live ones.
Okay. So the next question is the following. What is the recommended treatment after chemo and radiation? Is there anything else aside from Zometa, which this person is receiving every 6 months for 3 years?
So the standard treatment that is used for the treatment of triple-negative breast cancer currently. So again, chemotherapy, if it's indicated. We really try in many cases, or most cases, for triple-negative breast cancer to give that chemotherapy pre-operatively, so before surgery, because the response to that chemotherapy can be used to guide, next steps and to appraise the risk of recurrence. Surgery, radiation, if it's indicated, Zometa for some individuals is indicated. There are some people in whom we use other adjuvant chemotherapy or other chemotherapy after surgery. So there's some pill-based chemotherapy that we use for some people when they have their chemo up front, like prior to surgery, and they don't have a great response to that chemo. The tumor doesn't shrink as much as we would like it to. Sometimes use some additional pill-based chemotherapy afterwards. That's been shown to reduce the risk of recurrence. We talked about PARP inhibitors for early breast cancer. That's an emerging treatment which might be useful in the future for BRCA carriers, but not for general triple-negative breast cancer. Immunotherapy is also an emerging drug for triple-negative breast cancer, used either preoperatively and postoperatively along with chemotherapy. Not yet approved in Canada, but this is another emerging therapy for high-risk triple-negative breast cancer. And then a variety of other strategies are being tested in clinical trials. So a pretty limited number of standard treatments that are available today, but a variety of investigational strategies that are being tested or developed. And those really apply specifically to people who are at higher risk of recurrence, right? The goal of developing add-on or new strategies is and should be focused on those people who really need it, right? Those who are at highest risk of a recurrence, for whom some additional treatment, recognizing that additional treatment will have some type of toxicity and will have some cost ultimately, is directed towards those who are most likely to benefit from it, right? Rather than those who are probably cured by the standard treatment that they've received.
Okay, next question. When is the addition of Saloda recommended as part of chemotherapy?
Yeah, so Saloda is that pill-based chemotherapy. Saloda or capecitabine is the pill-based chemotherapy that I just alluded to. So for triple-negative breast cancer, our current standard today, and again, there's some variability in practice and it's a moving target. But generally, Saloda or capecitabine is indicated when people have had preoperative chemotherapy. So they had their intravenous chemotherapy before surgery for higher risk triple negative breast cancer. They have surgery where the tumor has not been eradicated in the breast or the lymph nodes. So there remains invasive cancer in the breast or the lymph nodes. And you can sort of draw different thresholds of how much disease and here individual decision making obviously goes into it. But it's in those people. So it's people who have residual disease at the time of surgery for triple negative breast cancer following neoadjuvant or preoperative chemotherapy. And there we use pill-based chemotherapy for it's usually 6 to 8 cycles of pills in that adjuvant setting or after surgery. And that's been shown to reduce the risk of metastatic recurrence of triple negative breast cancer.
Jen, we're going to go to live questions.
I think we're going to put 4 in here. We're back to the genomic profiling piece.
Sure.
So maybe we can group these together and sort of go back to that for a minute. So is there any benefit for tumor-based genomic profiling and protein receptor for early stage triple negative breast cancer to help in the case of recurrence?
Again, great question. And the answer, really today is no. So tumor-based genomic profiling for early stage triple negative, so non-metastatic triple negative breast cancer would not influence the treatments that we deliver today. From the tumor-based information, from tumor-based profiling, you can get the BRCA status because the tumor, would also have the BRCA mutation that you can detect in the blood. But really the standard way to assess that currently is, blood or saliva type of germline testing. So the tumor-based testing on its own, unlike for ER-positive breast cancer, right, where genomic profiling of the tumor using, one of any number of commercial tests that are approved for ER-positive breast cancer to assess risk, right? You have Oncotype, Mammoprint, Breast Cancer Index, PAM50, and there's a number of these studies, a number of these tests. For triple negative breast cancer, those are not a routine standard approach and would not influence treatment management.
Okay, yeah, and someone's asking the same thing around, like, given that the nature of the recurrence is same biologically, a lot of the times as the original tumor, to what you were saying, they're asking, wouldn't it be beneficial to test the original tumor? But really then if you had a recurrence, you would maybe do the genomic testing at that point in time, also recognizing that there might be some other markers you're looking for, depending on the treatments that are available if that recurrence takes place.
Yeah, so that testing could be done either on the recurrent tumor or on the primary tumor. One of the protein receptors for early stage Tnbc, so one of the protein receptors we talked about at the very beginning was called PDL1, right, or programmed death ligand. This is related to the immune system. It's a marker for immunotherapy, right? The discovery of this is what won the Nobel Prize a couple of years ago. So that marker is relevant to treatment for metastatic breast cancer and the use of immunotherapy in combination with chemotherapy for metastatic triple negative breast cancer. Immunotherapy is emerging as a treatment for high risk early triple negative breast cancer, but in that setting, its utility appears not to depend on PDL1. So PDL1 testing for early breast cancer then wouldn't have a role because those immunotherapies seem to be useful irrespective of the PDL1 status, where for metastatic disease, the benefit of adding immunotherapy is exclusive to those who have expression of PDL1. Now that expression could be from the primary tumor, could be from the metastatic tumor, but it's only for people with metastatic disease where it would influence the management.
Okay, and then this question, a little bit more specific, and I'm not sure if you're familiar with this trial or not, so we'll give it a shot and you can tell me yes or no. So your hospital is currently doing a clinical trial with the Signatera tumor marker test. Is it possible for patients outside of the Toronto area to participate in any of these clinical studies? So maybe you could speak to that specific one if you're aware of it, but also others in general.
Sure. So I think that, it's a great question about clinical trials in general. And as we've discussed, historically, treatment options for triple negative breast cancer have been quite limited. We're seeing some new agents emerge, which is great. And obviously, the availability or the demonstration that those treatments are useful has been because they've been tested in clinical trials, right? So clinical trials are critically important, have been critically important to the optimization of treatment strategies for breast and other cancers. And people participating in clinical trials, it represents a major contribution to the effort to improve treatments for everybody, but also provides opportunities for people to potentially access new and emerging treatments, which might prove to be useful, right? We don't know, obviously, at the time that the clinical trials are being done, whether those studies will be successful or not, but it provides at least opportunities potentially for other treatments. And so for many of the, the emerging treatments for standard of care treatment for breast cancer, now we at Princess Margaret, where I work in Toronto, or other centers around Ontario or throughout Canada or through the Canadian Cancer Trials Group, have been involved in those studies. And so, Canadian patients who have participated in those studies have helped to make these emerging treatments available to everyone, right? So I think that's my big plug for clinical trials, is that I think clinical trials are critically important to the overall development of the field, and for many people represent, good treatment opportunities. And the American Society of Clinical Oncology or other groups have often said that the best treatment for a patient would be a clinical trial that applies to their situation, right? The reason why clinical trials are done in certain situations for certain groups of people is because there's a potential therapeutic opportunity and an unanswered question. So who can participate in clinical trials? So many hospitals have clinical trials going. There's many clinical trials that are ongoing across Canada and throughout the world. And we at Princess Margaret in particular have quite a large breast cancer clinical trials program, which spans early breast cancer through metastatic breast cancer at different lines of treatment, and encompasses triple negative breast cancer, as well as obviously HER2 positive and ER positive breast cancer. What we try and do is to have a portfolio of studies available such that we can offer people in those different settings a potential opportunity for a clinical trial. So, first line triple negative breast cancer, second line triple negative breast cancer, first line HER2 positive breast cancer, second line HER2 positive breast cancer, if we're thinking about treatment for metastatic disease, right? Or early triple negative breast cancer, early HER2 positive breast cancer. So we try and have a slate of clinical trials that makes opportunities available to as many people as possible. And in order to productively contribute to those clinical trials, we absolutely depend on referrals of patients for clinical trials who are not in our, Princess Margaret catchment area, right? We're Princess Margaret, we're like the local hospital for the downtown Toronto area. And so we see that, the people who surgeon is in the local downtown area, just with, routine, very standard treatment. But we also, again, have this emphasis on clinical trials and other more complex situation where we draw from a much larger catchment area, right? And for clinical trials, really, we can and do see patients from around the Greater Toronto area, Southwestern Ontario, recognizing that traffic in the GTA where people have to come for a clinical trial means that there are limits to how far people can come. Some studies do have limitations on you have to live within 90 minutes of a center or something like that. But in most cases, we're able to draw from a large area of Southwestern Ontario. We see patients from, I would say, occasionally London, but Kitchener-Waterloo, Grand River area, commonly. Used to be an hour drive when I was in high school. Now it's probably substantially more than that. Hamilton, Barrie, north of there, east to the eastern end of the GTA. And then obviously there's other centers that cover other areas of the province as well. And I think the same probably applies in many provinces, that there are different centers that tend to have more emphasis on clinical trials. And many other cancer centers, smaller cancer centers, community cancer centers have clinical trials as well. They just tend not to have the same number or breadth of clinical trials, or sometimes the complexity of trials, just because we're fortunate to have the infrastructure to be able to do more studies, right? So that's the landscape. We, for breast cancer, myself and my colleagues, we really try and work with our colleagues in community cancer centers or other academic cancer centers to align our clinical trials as best we can with theirs, so that between us, we can offer the most different opportunities for people, right? Rather than having the same study open at two places, within the downtown area. And we regularly communicate the list of clinical trials that are open and enrolling patients. So yeah, patients themselves can find out about clinical trials through a variety of online resources. So clinicaltrials.gov is a standard registry for clinical trials that anybody can search. I think CBCN, we must have some clinical trial sort of access for advisory information. And there's other similar advocacy groups within Ontario and across the country, which again, I think try to maintain some registries for this. But in addition to that, we communicate directly with a large group of breast cancer medical oncologists who keep people up to date about what's opening, what's coming, what's closing, right? If someone wants to be referred for a clinical trial, and then we try and see those people as efficiently as possible. Before seeing them, we try and carefully review the relevant information so that we're bringing people who are likely to qualify, or where the study is likely to be appropriate for them, so that we can help run this for everyone in the most efficient way as possible. So that kind of outreach is important, and because of that, we've been very successful in enrolling a lot of people to these studies. We've obviously had people who've been treated on clinical trials who had access to treatments that have now become approved or will become approved treatments, and we seem to have had good outcomes. So I think for the whole field and for the individuals involved, it's very productive. So the specific study now that we get to, so let me find this question here. Did you already put in the answer question?
No, I think I already put it in the answer.
Yeah, it was about the Signatera trial. So we do have a study which is ongoing, the one that you're referring to, which is a clinical trial for patients with either BRCA related, so someone with a known BRCA1 or BRCA2 mutation. And for them, it's irrespective of whether their disease is triple negative or ER positive, or triple negative breast cancer. And that's triple negative breast cancer, which may be related to BRCA1 or 2, or is not related to BRCA1 or 2. So it's not specifically triple negative, it's triple negative and or BRCA related breast cancer. And what this study is doing is along the lines of what I described earlier, right? Really trying to risk stratify people. So is there something else, right, that we can use to identify people who are at the highest risk of recurrence, right? And here it's not imaging. So imaging is not the surveillance, we can't see with imaging. Once somebody has something on imaging, they already have metastatic disease. This is using a blood test. And as Christine in the question notes, the blood test that's being used as part of the study is called Signatera. This is a blood test, or something called the liquid biopsy, which is looking for what's called circulating tumor DNA. So circulating tumor DNA. So it's looking for tumor DNA that is circulating in the blood after someone has completed their treatment, right? So you could imagine that once you finish your standard surgery, radiation, chemotherapy, whatever other treatments you're going to have, once that is done, if there is still signs of the tumor DNA in your blood, right, it implies that there's some tumor cells somewhere in your body that are shedding that DNA. Right? We know this DNA doesn't hang around a long time, but so it must be constantly produced and shed into the bloodstream. So Signatera is one of a number of different tests that are being developed to try and identify circulating tumor DNA, or here what's called molecular residual disease, because you're looking for DNA, it's a molecular structure, right? So molecular residual disease, right, in someone who doesn't have any radiographic evidence or no CT scan or chest X-ray evidence of disease, right? As far as we can tell, that person is healthy, right? They've completed their upfront treatment, but now they have some marker in the blood that there's some tumor cells left behind. And this is, again, an emerging field, but it appears, and the data thus far is pretty compelling, that if you have circulating tumor DNA in your blood following the completion of standard treatment, the risk of a recurrence is very high, right? So what this study is doing is actually screening people with this marker, right? Where many or most people won't have circulating tumor DNA in their blood, which doesn't mean that they won't recur, but might mean that they're less likely to recur in at least the short interval of follow-up. The focus though is on those who have a positive test, and then those people with a positive test are eligible for potential treatment with escalated therapy. And here the escalated therapy is the PARP inhibitor. It's again targeted therapy that similar to the type of treatment that we now know is useful for some women with BRCA-related breast cancer, may have a role in the triple-negative breast cancer as well. So we have the study, which is currently enrolling for triple-negative and BRCA2-related breast cancer. Absolutely, we see patients from outside of Toronto for this study. Again, outside of the province is much more difficult for clinical trials just because healthcare is provincial jurisdiction. But we do see people from outside of Toronto. It's a pretty straightforward study for most people where it really just is the blood testing that happens initially, because most people are not eligible for the treatment part because they don't have the positive test. But this is this concept or notion of what's called cancer interception, right? Intercept the recurrent disease before it happens by detecting circulating tumor DNA is an area of great interest and ongoing research. This study, as I said, is a study which is taking place at our center and many centers around the world, probably a couple hundred sites around the world for BRCA-related and triple-negative breast cancer. And we're working at Princess Margaret. There's been a lot of work done on this concept of circulating tumor DNA, liquid biopsy, and we're excited to be able to roll out hopefully additional studies in this area soon, which would be for non-triple negative breast cancer, or with different strategies relevant to different types of breast cancer. And many of my colleagues are working on different strategies for other cancer types as well.
I think that's great to know. And then also, just as a follow-up, just quickly, Kathy, that in terms of navigating the clinical trials, because to your point, Dr. Cescon, sometimes it's hard to even navigate the various clinical trial sites. And that is something that CBCN is able to help with on an individual basis. If patients connect with us to try and help them navigate some of those sites that are a little overwhelming. So I would encourage people to reach out to us. Kathy, sorry.
No, I just wanted to keep with that thought in mind about the circulating DNA testing, which is very interesting and, quite appealing. If somebody doesn't get tested or is followed, like you said, there's no reason to follow a patient with any breast cancer after a certain point. Would that be implemented? What I'm asking is would that be something that would be a tool to measure if somebody could recur or start recurring?
Yeah, so I think, you're right. So this is a potential tool for that, right? Whether it is a clinically useful tool remains to be seen. So for it to be a clinically useful tool, it needs to be something that can, like the positive test has to mean something, right? As in terms of risk of recurrence, we have to be able to interpret what that means. And really, ideally, we need to be able to do something about it, right? So if intervening at the time of a positive test doesn't change the outcome, then that kind of, you could imagine that rolling out this kind of surveillance with a blood test, which is, obviously costly, complicated, gives people information that you can't do anything about, right? If you say, listen, you have a positive blood test, but we don't know what to do with it, it just means that you're at high risk and we don't have a treatment for it, then it's not useful, right? So that's the clinical utility piece. But studies like this one that Christina has asked about, like other studies that are being developed, that's the goal of those studies, really, is to show that not only can you detect something, but that you can do something about it that improves people's outcomes. If those studies are successful, right, that they actually show that intervening on the basis of a positive test like this can improve people's outcomes, then this is a potential surveillance tool that could be implemented. And the way that it's implemented, would have to be risk stratified, right? So someone who has, a very low risk breast cancer, doing a test like this where, they're 99.9% not likely to have a positive test, you have to test 100 people to find one positive test, where the tests are costly, is unlikely to have clinical utility in the long term or be, feasible. or cost effective for the healthcare system, but identifying people who are specifically at high risk, it could be a very useful strategy, right? And so you could imagine we talked about capecitabine, where we use that in people on the basis of the presence or absence of disease at the time of surgery after they've completed chemotherapy. So, the reason why we use capecitabine in those people is because, or Saloda, is because those people are at higher clinical risk. So we're already using that clinical information to guide an intervention. Well, here you could use clinical information to guide testing, right? Like, this person is high enough risk that it would make sense to do some kind of surveillance testing. But again, the surveillance testing has to lead to something. The idea in ovarian cancer of measuring blood-based markers, CA-125 historically, which was monitored in many people. When some studies were done of that, and it's been a while, and I'm not totally up to date on that field, but when some of the earlier studies were done at CA-125, it showed, yes, you could measure these things. You could detect CA-125 rising after someone's diagnosis. CA-125 was associated with a worse outcome, but it didn't improve. Nothing that was done about it improved people's outcomes. And measuring these things has downsides in addition to the cost, et cetera. Just the idea of surveillance, and then the idea of getting a positive test that no one can tell you what to do about it, has downsides for people, right, who then have to deal with the consequences of this information.
I guess the CA-125 actually works better for people who are undergoing chemotherapy to see if there's an improvement during chemotherapy, right? See if
so it's used for monitoring metastatic disease in that way.
Yeah.
And again, I don't want to say that it's not used for surveillance now. It might be, but some of the early studies, again, did raise some concerns that, markers like that, if they don't lead to a changed or improved outcome in terms of survival or disease control or something, have downsides that are important. In addition, obviously, to the cost of doing these tests.
Are those costly? The DNA circulating?
So these are not real. Signatera might be a marketed test, but these are not really marketed tests currently. So how they're going to be priced is not entirely clear. We know that genetic tests in general, or tumor-based genetic tests and genomic tests in general, tend to be costly. And here, these are very sophisticated tests. So this is a couple of these. This Signatera and another one are tests that they depend on sequencing of the entire tumor. So complete genetic profiling of the person's tumor that's been removed, to be able to design a personalized fingerprint for that person's cancer that they can then go searching for in the blood. So it's a technical and fairly laborious process for which there are costs to do, along with the company's business model, which would obviously require them to generate a profit from that. So these are tests that would cost thousands of dollars, not tens or hundreds of dollars.
Okay. So Jen, can I go to a couple more questions that I have here? Do we have enough time?
We do, yeah. Maybe if you want to do one, and then I've got a couple more from our live chat still.
I'm going to go with two questions in terms of research. So one of the questions is around, let's see, is there anything promising in terms of research, clinical trials, or vaccines for both early stage or metastatic triple negative breast cancer? I guess vaccines would be an interesting answer from you, because with the COVID, mRNA
vaccines.
That would be my question around the vaccines.
So it's interesting, actually. So, cancer vaccines have been an area of development for many years. I can't speak to any specific vaccine product that I'm aware of that is particularly promising or not, but the idea of cancer vaccines, where again you could produce you could vaccinate someone against a given protein or multiple proteins so that their immune system could better recognize the cancer, is a concept that's been around for a long time, right? Probably 100 years. And the mRNA, actually, some of these companies that have been involved in the development of the COVID vaccines, their initial main line of investigation was anti-cancer vaccines. And the reason is because the technology is very amenable to the idea of identifying specifically mutated proteins based on sequencing of that tumor DNA, putting in the mRNA for that mutated protein so that you could immunize the person against the mutant cancer protein, their own, personal mutant cancer proteins, or personalized cancer vaccine. And there were studies at Princess Margaret, in the year before COVID, that were being run by some of the same companies that, subsequently have delivered billions of doses of COVID vaccine around the world through various partnerships. So I imagine that they will continue to, try and move that field forward. And they obviously have substantially greater resources, as well as have been able to optimize a lot of things along the way of developing the COVID vaccine. So I think that, I think in general, it's certainly an interesting field. This could complement the whole field of immunotherapy, which for many types of cancers has really, revolutionized the way that we treat solid tumors. For breast cancer, is beginning to make inroads. Those inroads are principally in triple negative breast cancer for immunotherapy, but the vaccine and immunotherapy angles obviously go hand in hand to some extent.
Okay.
Other than immunotherapy, are there others that you see in terms of like coming down the pipeline that would be promising for triple negative breast cancer?
Yeah, well, there are for breast cancer in general. So immunotherapy, both for early and advanced triple negative breast cancer, are treatments that are approved in other jurisdictions. The area of antibody drug conjugates. So these are antibody drugs that have chemotherapy linked to them. And there are some approved drugs, multiple approved drugs of this class for HER2 positive breast cancer, marketed drugs that are an antibody like Herceptin, which is against HER2, and then they have a chemo drug linked to it, right? So it's a way to give kind of targeted chemotherapy to the tumor. So there are other antibody drug conjugates. There's one now approved for triple negative breast cancer, in Canada, actually, and commercially will roll out in Canada hopefully soon, like as in this year, for metastatic disease. So that whole kind of field of antibody drug conjugates, targeted chemotherapy, and that way getting the chemotherapy to the cancer cells will be very relevant, I think, for triple negative breast cancer and other breast cancer subtypes. And then there's a variety of targeted therapies, obviously, that are continuing to be investigated.
What's the most promising thing you see in the near future? Oh, sorry, I didn't realize.
I think, it's the most promising thing. It really depends on what scenario you're looking at, right? Promising as in, how can we increase the cure rate for the people, as adjuvant therapy? There we've seen significant inroads with immunotherapy. PARP inhibitors look like they can have some impact there. I think what we need to do there is to be able to refine who we give these treatments to. And so this is where approaches like that liquid biopsy ctDNA may help us to better use our treatments most effectively. And so this whole field of diagnostics is one with great potential. For metastatic disease, metastatic triple negative breast cancer, again, hopefully by January or the early part of this year, we will have multiple new treatment options for Canadian women with triple negative breast cancer for drugs that are already approved in the US. That includes other immunotherapy. We have immunotherapy now approved for triple negative breast cancer in Canada, though it's not generally available to many patients because it's not funded, at least in Ontario. But so there'll be other immunotherapy in use of standard chemotherapy and one of these antibody drug conjugates that are hopefully coming soon. And I think especially for metastatic triple negative breast cancer, where our treatment options are limited, these will certainly add to the available tools in a meaningful way.
So in terms of being in the moment and keeping with the momentum, because breast cancer and cancer is such a fast-paced, or we want it to be fast-paced, because the more we do, the more we learn, the more we're able to succeed, for OS, overall survival. And that's what, most of us want to see. Do you feel that we are still in the momentum? Do you think that what's coming down the pipelines, we're still strong, research, innovation, are we still moving with the progress and the time?
Yeah, I think, in the last 5 years, we probably made more progress with triple negative breast cancer than in, from the time that triple negative breast cancer was defined, which was 10 years before that. So there definitely has been an acceleration in some impactful, diagnostic treatment management. It's not just with new treatments, right? It's the way that we use these treatments, the way that we, identify individuals who could benefit from them. That use of Saloda that someone asked about earlier, right? This is a drug which was not particularly useful chemotherapy for triple negative breast. It wasn't what we would call like our best chemotherapy for triple negative breast cancer historically, but when tested in this context of giving it to people after they've had their previous chemotherapy, the clinical trials showed a remarkable improvement in reducing lethal recurrences of triple negative breast cancer. So it's, using the tools that we have in the best way possible to get the best outcomes for every individual while trying to avoid unnecessary or costly treatment and toxicities from just throwing everything at everyone where they may not need it.
There's a lot to keep in mind as we move along, right?
Yeah. No, so I think there's a lot happening. There's a lot that will happen. And, as someone working in the field, both on the research side, right, really from bench to the bedside, we do basic research, we do clinical research and translational research, that it's, it's very rewarding to be able to, both participate in this and help make these new treatments available to people who, in many cases desperately need them.
Thank you. So Jen, do we have any, I know we have a lot, I haven't.
So Jen, maybe I was thinking actually, I see there's a list of Q&A.
Yeah.
Maybe, do you want me just to hit these questions quickly so we can try and get
let's do it
upon them as best
as
possible?
Yeah.
Sure. Okay, so that one, a question from the very start here. So Becky asked, so how will the approval of new adjuvant treatments for Tnbc in Canada affect patients that have already completed treatment within the last 5 years or more? So this is an insightful question. When we have new treatments so adjuvant treatment, so this is treatments given for people around the time of their cancer diagnosis, how will this influence people who had their cancer a year ago and had the adjuvant treatment? And often this depends on what the treatment is, exactly how it's used or what it's used for. You can think of Herceptin when Herceptin was developed as an adjuvant treatment for HER2-positive breast cancer many years ago, and it really showed dramatic benefits. That there was some uptake or rollout to this, perhaps in people who might have kind of missed the window of when that treatment would have been used in the clinical trial. So, a drug used in a clinical trial, it might be, a drug, for example, a PARP inhibitor in the adjuvant setting. Patients had to start this within 12 weeks of completion of their standard treatment. So you can imagine, a drug is now approved. You've been 6 months since your standard treatment. Should you have access to that or not? Could it be useful to you or not? And the answer is we don't know. How these things are rolled out really depends on the approval that's granted by Health Canada, whether there's specific timelines attached to it, access to the drug. I think it's important not to extrapolate, results of clinical trials for something like that, like if it had to be started within 3 months, someone who's 5 years out from treatment, right? Because as we've already talked about, someone who's 5 years out from Tnbc is probably not going to have, almost certainly not going to have a recurrence. And so giving them some extra treatment that has toxicity would not be warranted. It would not have the same risk benefit that it would have when given up front. So complicated question. Often in these situations, there may be a little bit of flexibility in how we do this, but generally, especially for triple negative breast cancer, where the recurrence risk tends to be high early and fall off relatively quickly, that we would not reach far out into that post standard treatment period to deploy new therapies. Does that make sense?
That's helpful. That was great. I had the same question, and so I'm glad you got to that. All right.
Okay, so let's see.
Continuing
the next
on.
one. So the next one about COX-2. Again, this is sort of a very specific question about COX-2 inhibitors in triple negative breast cancer. Some drugs like aspirin are being studied in breast cancer to prevent recurrent. Aspirin is a COX-2 inhibitor. So this pathway is of interest, but not a specific clinical role today. There may be clinical trials. This is one thing where it would be worth having a look at if there's any ongoing clinical trials that one might be eligible for. Carol Ann asks, are there any immunotherapy or alternative medicine supplements which would be helpful? Again, alternative therapies are generally alternative because they've not been proven to be beneficial or studied in a way that shows conclusively that they have value in improving outcomes. In general, I discourage many of these things, particularly during times when people are getting standard treatment, like should I take the supplement or this intravenous vitamin C while I'm having chemo? And my answer is no. The reasons are we don't know that these things might interfere with the proven effectiveness of standard treatments. And we do know that many alternative treatments confer toxicity. So common reasons why people have elevated liver enzymes or other things when they're being treated on clinical trials is because they're taking some alternative thing which is contributing to that. So there's a lot of unknown. Could it make your standard treatment less effective? Could it increase the toxicity of the standard treatment? I refer people to Memorial Sloan Kettering has a very nice website about integrative medicine, and you can look up different supplements and it provides some information around there. Is radiation standard treatment with triple negative if a patient has had a mastectomy? So radiation, so what's called post-mastectomy radiation for triple negative breast cancer really depends on the size of the tumor and the proximity of the tumor to the tissue margins. And again, I don't think it's important that these decisions are informed on an individualized basis. So just because someone has triple negative breast cancer doesn't mean that they need everything, right? They still have to have a risk-adapted treatment from a multidisciplinary team. So where the surgeon, the radiation oncologist, and the medical oncologists are contributing. Shannon, what's the effect of stress on recurrence? So again, an area of significant interest. I don't have any particular statistics to provide you on this, but certainly things that may help to reduce stress, like exercise, could be valuable in many ways. What helps neuropathy in the feet? Again, neuropathy in the feet can be a challenging complication of some chemotherapies, including taxanes. Fortunately, for most people, this improves with time. For painful neuropathy, there are pill-based treatments that can be useful to help reduce the painful symptoms. Again, it's something I would encourage an individual to discuss with their medical oncologist around strategies to address their specific symptoms. And finally, is P10 variant gene at risk? So P10 is a gene that was partially discovered or characterized in Toronto at Princess Margaret, actually. So P10 is a gene that can be mutated in breast cancer. So you can acquire your breast cell or your other cells can acquire a mutation in P10, which may be relevant. There are inherited variants in P10 that can predispose people to a variety of cancers, not just breast cancers. P10, germline P10 or inherited P10 alterations are rare, much less common than the BRCA1 and 2 mutations that we talked about, but it can be a risk for breast cancer. Again, depends on the specific context. And someone with a P10 germline variant, this should be discussed appropriately with the genetics team at their cancer center.
Wow, thank you so much. This has been an amazing hour and a half. Honestly, we didn't even go through all the questions. I really thank you so much. Jen, you want to do closing remarks?
I would echo Kathy's sentiment. I think thank you everyone for your wonderful questions, Dr. Cescon for plowing through all those. And also I recognize we didn't get to all of them from today, but I think we touched on a lot of what were submitted in advance as well. So Kathy, thank you for hosting today. Dr. Cescon, thank you again for being with us. And also for today's sponsors, our gold sponsor, Viatris, our silver sponsors, Novartis Oncology and Roche, and our bronze sponsors, AstraZeneca, Knight Therapeutics, Ontario Trillium Foundation, and Pfizer. We will be sharing a short survey in the next day or two with everyone. We would really appreciate your feedback. So check your inbox for that. And thank you again, everyone, for joining us. Have a great afternoon. Take care.
Thanks, everyone.